Divya Sriharan here. I'm an advanced certified lactation professional. So with regard to positioning and latching, I think these words must have been very commonly used by nursing staff, by pediatricians, by obstetricians during their visit, during your antenatal care and postnatal care. But how well are mothers taught with hands-on support on positioning and latching, putting the baby at the breast, seeing which position is comfortable for the mother and the baby. Again, while talking about positioning and latching, I would try to strongly establish that there is no rules in breastfeeding. When I say this, there is no hard and fast rule that there is only one or two positions which will work for every mother and baby. There are n number of positions, and it's left to the mother and baby to explore more. But I can demonstrate some basic positions and some basic guidelines in terms of position that will help you with painless feeds and help in more milk transfer to the baby to get an optimal latch. So let me start with the cross cradle hold. Why I would stress more on cross cradle hold during the initial days is it has a good control of the head. So in the cross cradle hold, the first basic is baby's head, body and buttocks is along the same line. Whichever breast you are offering to the baby, with the opposite hand, you completely support the baby up to the base of the head. So we are not putting pressure on the head here. It's only support to the base of the head. And whichever breast you're offering to the baby, the same hand as the breast supports the breast in a C or a U. This plumping of the breast helps in a deeper latch. When we squeeze just the nipple and give, or when we are using a scissoring hold while attaching the baby at the breast, there is always a chance that the baby most often has a suboptimal latch or just feeds at the nipple. So enabling the baby to just get a smell, express few drops, tickle the upper lip of the baby. Why do we have to tickle the upper lip of the baby? This helps in the rooting reflex. So when we tickle the upper lip, the baby opens wide. And when we wait for the baby patiently to open wide and then give a quick hug with this hand. So steadiness of this hand and positioning and alignment of the baby really helps. Once the baby has started suckling and you feel no pain, you just feel a big grab and not clenching or gumming at the nipple, you can bring your other hand also in support of your existing hand so that you are having proper positioning and supporting yourself well. And I would like to say that irrespective of whichever position you're using for your baby, first and foremost thing is to bring the baby to the breast and not bend down and bring your breast to the baby. Because when you are not supporting your back completely, it's not just one or two feeds in a day, but multiple feeds, a minimum of 8 feeds in 24 hours. So you will be hurting your back most often if you're not going to bring the baby to the breast. And bending down and giving the baby to your breast will not help not straining your back. So this is the cross cradle hold which I just demonstrated. The other position that I would suggest in the early weeks, especially in terms of cesarean mothers, is the football hold. Football hold, I would rather stand up. So tucking the baby from the side and completely supporting from the buttocks to the base of the head, and the same basics. Tickle the upper lip, wait for that big mouth opening, and attach the baby at the breast. So you can use feeding pillows to bring to the height level of your hand and your baby. The feeding pillow is again not to completely support the body of the baby, but to support your hand. So football hold is helpful in cesarean cases mostly because you don't have pressure on the site of the LSCS. So abdominal stress can be avoided when you do a football hold. And there are other positions, but my favorite in terms of breastfeeding challenges has been the laid back position, which we also called as biological nurturing. Right? If you have had a normal delivery, most often you'd have seen this beautiful process of putting the baby on your abdomen and breast crawl happens. wherein the baby crawls up to your breast and initiates the feed. And that's the same principle that we use in laid back or biological nurturing. So mother is completely reclined. I'm not able to recline myself right now. So you put your baby across your breast and try to latch your baby. So the baby will be completely across your breast and again supported from the base of the head. And you use your hand in a C or a U. Please remember not to use scissoring hold or just squeezing your nipple will not help you much. Why? Because nipple feeding is not what we want. We want a good deep latch of the baby around the areola with the mouth full of breast. So just feeding at the nipple will cause injuries to the mother, pain to the mother, and very less a drip, a drop, a drip, a drop of milk to the baby. Whereas a mouth full of breast will help the baby getting more milk and will also stimulate the breast better for better milk supply in the coming days. So positioning and latching during the initial days and seeking support from a trained, skilled professional will help mothers in the coming days in establishing breastfeeding. Refusal. We are seeing it more often in hospital these days because it could be because of n number of reasons. It could be trauma during childbirth. It could be the way the baby has been handled by the obstetrician, by the pediatrician while evaluating, which might have caused some damage to their neck muscles. And it could also be other conditions of restrictions in the baby's muscles, which is why sometimes usually we see breast refusals happening unilaterally. They refuse one particular breast sometimes. And we also see cases wherein both the breasts are refused. That is, the moment the baby is offered the breast, the baby has a sharp, loud cry. Baby just arches and pushes away from the breast. So why does this happen? From my clinical experience, what I have seen is number one, it can happen when the mother and the family or the nursing staff and the team has been repeatedly forcing the baby at the breast over time with wrong positions, right? When you're not using correct positions, when you're going to push the head of the baby into the breast, it is definitely not going to help the baby in any way because the head is extremely sensitive and they might completely reject at one point. An improper positioning wherein baby has just been feeding at the nipple, baby gets demotivated because baby is just getting drops of milk, and at one point baby thinks that I have to put in so much of effort to extract those few drops, and their only way the babies can communicate is either by going off to sleep or by completely rejecting and crying at the breast. These are the signs that the baby is showing that baby is not very comfortable in that particular position or the way the breast is offered. So breast refusal in these cases can be handled by seeking proper lactation support by a lactation professional who is trained in proper positioning and helping you with on hands. So explore by not forcing the baby. Don't repeatedly force the crying baby at the breast. Seek support, evaluate further as to what is the underlying cause for this refusal, right? And it can be different in every baby. Some babies might have this condition called torticollis, wherein they are not able to latch. They have severe strain in their neck muscles where they cannot really grab at the breast. So evaluate with a healthcare provider who is trained to rule out these causes so that you can have a painless and comfortable baby at the breast. The other reasons could also be, less skin to skin, less bonding. When there has been separation from the mother and the baby has been in the NICU for a long time, wherein breastfeeding has not been established. So this separation can also cause rejection at the breast. So a lot of skin to skin, kangaroo mother care, and slowly offering the breast with baby not having sharp cries with proper positioning will help bringing baby back to the breast. We can also use other breastfeeding aids like drip drop feeding, SNS, which is supplementary nursing system at the breast, or finger feeding at the breast, which can help bringing baby back to the breast. But most often, I see that in cases of breast refusal, mother is always blamed because the fault is always found with the mother, that she does not have well formed nipples are flat, nipples are inverted, she does not have enough supply, which is why baby is refusing the breast. But with proper evaluation, we have most often seen that it is somewhere about how we are positioning, how comfortable the baby is, and also about guiding the mother with appropriate plan of care at the earliest without delaying the process of support. So please don't blame mothers, but support families better. That will help them with handling breast refusals. What I would like to say to new moms who are facing conditions like breast refusal is, please do not let people blame you. Don't take it on yourself. Please seek for support. It's okay to ask for help, because I see that families are apprehensive to go to a lactation professional for help. Just like how you have fever, cough, cold, and you go to a physician or a doctor for help. This is also a condition where mother needs support. She just needs to talk to the professional who is going to help her with a painless feed. Breastfeeding is not supposed to be painful or traumatic. Breast refusal can be traumatic in most cases, which can also lead to postpartum depression, which we have seen. So seek help so that you can be happily. So this year's World Breastfeeding Week theme has been supporting working mothers and families with continuing breastfeeding. And I think this is something very critical as healthcare providers and also for families, so that we know that getting back to work is not going to stop the mother from breastfeeding or providing her breast milk, which is also a way of breastfeeding to her child, right? And according to WHO, we strongly recommend continuing breastfeeding as the primary source of nutrition for the baby at least up to 1 year, along with complementary foods which are to be started after the completion of 6 months with the help of your pediatric team. So, with regard to working mothers, it is a good idea that you sit along with your lactation professional and discuss at least a month or so before you plan or intend to join back to work. Three things that I would strongly recommend for working mothers is to sit along with your lactation professional at least a month or so ahead of the intended date of joining back to work, and discuss on major points, which are pumping and storage of breast milk. How long are you going to be staying away from your baby while you're at work? Third thing is transportation back home of your pumped or expressed breast milk, and how to get back to the breast with direct breastfeeding, working along the schedule once you get back home, so that you can still continue direct breastfeeding as much as you can. So with regard to pumping and storage, there are different types of pump, and it is not generalized for every mother. But ideally, for a working mother who is going to be away at least for 8 hours a day, I would strongly recommend to invest in a good electric pump, and most importantly, with the correct flange size. Because flange size of the pump, whichever manual, electric, or hospital grade pump that you're going to be using, plays a very important role in the amount of milk that is going to be collected. So please take help in finding out which is the correct flange size for your particular breast, and then go ahead with purchasing so that you're comfortable with painless pumping sessions and you're able to get optimal amount of milk extracted. With regard to storage, please make sure you are storing in proper containers. With a lot of studies and research on microplastics and breast milk, I personally suggest in starting to store in stainless steel containers or glass containers, which are sterilized. And storage rules, please keep in mind, it's very simple rule of 4. 4 hours in room temperature, up to 4 days in the refrigerator, and up to 4 to 6 months in the freezer. This is going to be your storage guidelines, and make sure that you are having a cold chain storage and transportation, which is you can use the cold storage boxes, insulated, or have ice packs along your storage boxes so that the cold chain is maintained. Please discuss with your team at the workplace whether they have refrigerators available, whether they have freezer available exclusively for storing breast milk for working mothers. it's a good idea to have this discussion well ahead before joining. So I would always recommend to sit along with your team and work on your pumping schedule so that you keep up with your supply, because there should not be long hours of gap between pumping sessions as well. So yeah, that would be my few tips for working mothers. Most often we see that either during the hospital stay, by the second or third day, or the mother comes back in the first 1 or 2 weeks and she says that I'm having severe pain. And then when we evaluate, we see that there are cracks, there are soreness, there are open injuries, in some cases, even bleeding. And it's very sad to see the mother, because it's not easy to continue direct breastfeeding with so much of pain. And in cases of soreness, cracked nipple, or nipple injuries, please identify the underlying cause and treat the underlying cause rather than symptomatic treatment. Rather than just treating by giving a nipple cream that is going to be just a band-aid for the existing soreness or injury, I would strongly suggest to please dive in and evaluate the latch with the help of a lactation professional, so that it doesn't happen like a cycle. When the baby is going to have a suboptimal latch, clenching only the nipple, obviously the mother is going to end up with soreness and crackness. So you know now that what is to be addressed, right? Nipple creams do help very rarely, but I would say that applying your own hind milk and air drying it, and along with that, focusing more on evaluating direct breastfeed, positioning and latching, trying out other positions with the help of a professional will help you with a permanent solution for your pain and soreness, cracks, or injuries.